Picture this. You're in a high-stakes, chaotic environment of an emergency room. The double doors just burst open. A patient is rushed in, gripping their chest, sweating profusely, totally struggling to breathe. In this exact moment, every single second counts. Welcome to this explainer on acute coronary syndromes, or ACS. Today, we're going to walk through the intense clinical pathways that literally dictate life or death in these critical moments. We are talking about an absolute race against time where the heart muscle is starving for oxygen, and medical intervention is the only thing that can restore the supply. So to manage a crisis like this, we're going to follow a very strict clinical pathway. Here's our game plan. First, the anatomy of ACS. Second, diagnosing the danger. Third, treating high-risk STEMI. Fourth, managing end-STEMI ACS. And finally, secondary prevention after MI. All right, let's jump right into part one, the anatomy of ACS, and understand the biological crash. What is actually causing this catastrophic emergency deep inside our patient's chest? Well, it's basically a biological traffic jam that turns deadly. It actually starts completely silently, often over years, with step one, endothelial dysfunction and the formation of these fatty streaks, which eventually build up into atherosclerotic plaques. But the acute crisis, the emergency, happens in step two. Over 90% of the time, ACS is triggered when one of those unstable plaques suddenly ruptures or fissures. This rupture exposes collagen and a highly thrombogenic lipid core, which is rich in tissue factor, right to the bloodstream. And immediately, we hit step three. Platelets rush to the site, they adhere, and they activate. They start sending out these chemical distress signals like ADP and thromboxane A2. This causes vasoconstriction and literally calls in even more platelets. Finally, in step four, a conformational change happens in the platelets' glycoprotein 2b3I receptors. They link together with fibrin strands, trap a bunch of red blood cells, and boom, a massive fibrin clot forms, completely blocking the artery. And really, that brings us perfectly to the formal definition of acute coronary syndrome. Officially, it's any syndrome compatible with acute myocardial ischemia, resulting from a critical imbalance between myocardial oxygen demand and supply. Because of that sudden clot we just mapped out, the coronary artery is totally blocked. The heart muscle, continues to demand oxygen so it can pump, but the supply has been entirely choked off. That starvation, that is exactly what's causing the severe, radiating chest discomfort our patient is feeling right now. Moving right along to part two, diagnosing the danger, the ultimate fork in the road. The biology has crashed. Our patient is presenting with midline anterior chest discomfort. It's radiating to the jaw and arm, and it's been lasting well over 20 minutes. We know we have an emergency on our hands, but to save their life, we have to figure out exactly what kind. The ticking clock starts the absolute second they walk into the hospital. We have a strict 10-minute window to obtain a 12-lead electrocardiogram, or ECG. Why 10 minutes? Because time is muscle, and the ECG is literally the only tool that can instantly tell us just how bad the blockage is. This right here is the most crucial fork in the road for our entire treatment plan. The clinical pathway physically splits based on the heart's electrical readings. On one side, you have STEMI, ST segment elevation myocardial infarction. If we see ST segment elevation or a new left bundle branch block, that tells us the artery is 100% occluded. The patient is at an incredibly high risk of death. Now, on the other side, we have non-ST segment elevation ACS, or end-ST ACS. With this one, the ECG might show ST depression, T-wave inversion, or honestly, it might even look completely normal. So we can't confirm a heart attack just yet. We actually have to rely on biochemical markers like cardiac troponin in the blood to prove that myocardial cell death is actively happening. Let's follow the most dangerous path first. In part three, treating high-risk STEMI, the race to reperfusion.
So our patient's ECG shows a STEMI. The artery is totally blocked, the heart muscle is literally dying, and we have to immediately reestablish coronary perfusion. The chaos of the ER is met with highly targeted pharmacological warfare. Every single drug we throw at a STEMI patient right away has a specific job to target that biological crash we looked at earlier. We give sublingual nitroglycerin to dilate the veins and drop the heart's oxygen demand. We aggressively push antiplatelets, like chewed aspirin and a P2Y12 inhibitor, think clopidogrel or ticagrel, to stop those platelets from clumping up. We bring in anticoagulants like unfractionated heparin or bivalirudin to freeze the coagulation cascade. And we administer beta blockers like metoprolol or atenolol to reduce the heart rate, basically forcing the heart to rest and decreasing its demand for oxygen.
But here's the thing. Medications alone aren't going to clear the highway entirely. Our ultimate primary goal for a STEMI patient presenting within 12 hours of symptom onset is a door-to-balloon time of 90 minutes. That means from the moment they walk through those hospital doors, we have exactly 90 minutes to get them into the cardiac catheterization lab for a primary percutaneous coronary intervention, or PCI. We go in, physically inflate a balloon, place a stent, and pry that blocked artery wide open. Okay, but what if we're in a rural hospital without a cath lab? What if we can't transfer the patient for a PCI within 120 minutes? That is when we have to pivot to fibrinolytic therapy. We use heavy clot-busting drugs like alteplase or tenecteplase. But these are powerful drugs, and they come with very strict rules. They absolutely must be administered within a 12-hour window from the onset of symptoms. And ideally, we want to push these drugs within just 30 minutes of the patient arriving at the ER so we can dissolve that fibromesh before the damage becomes permanent. Right, so we've successfully navigated the STEMI pathway. But let's just rewind the clock for a second and go back to that diagnostic fork in the road. What happens if our patient arrives clutching their chest, but that initial 10-minute ECG does not show any ST segment elevation? That takes us into part 4, managing NSTEMI ACS through a stratified approach. The immediate stabilization looks pretty similar to STEMI. They're still getting oxygen, aspirin, and nitrates, but the overarching strategy from there requires a much more nuanced, risk-stratified approach. For NSTEMI, our secondary clinical pathway is categorized strictly by risk. If a patient is high risk, say they have recurrent ischemia, heart failure, or their troponin levels are actively spiking, we opt for the early invasive strategy. We give them anticoagulants like heparin or bivalirudin, and we plan to get them into the cath lab for an angiography and potential PCI within 12 to 24 hours. But if they are lower risk, we might choose an early conservative strategy. Here, we manage them medically with drugs like enoxaparin or fondaparin X, and we just observe them closely without immediately rushing to invasive angiography, unless, of course, their condition starts to worsen. Now, here is a massive, absolute hard and fast rule you have to remember. While the medical management shares a lot of similarities with STEMI, fibrinolytic therapy is never, and I mean never, administered in NST-ACS. Because the artery isn't fully occluded by a massive clot, using heavy clot-busting drugs offers absolutely zero mortality benefit. It just exposes the patient to a devastating, completely unnecessary risk of major bleeding and intracranial hemorrhage. We just don't do it. Okay, let's take a collective breath here. The immediate, life-threatening emergency is over. Whether it was a STEMI cleared by a balloon in the cath lab or an NSTEMI managed with risk-stratified medication, our patient is now stabilizing in a hospital bed. But you know the journey is far from over. The heart has suffered a major trauma. So how do we ensure they don't end up right back in the ER next week? This transitions us perfectly to the final and honestly, arguably most impactful phase of care. Part 5, secondary prevention after MI, long-term maintenance. After a myocardial infarction, the heart undergoes a process called ventricular remodeling. Basically, the left ventricle can dilate, lose its pumping function, and rapidly spiral right into heart failure. To stop this, we have to completely optimize their long-term pharmacy before they are ever discharged. Think of this as the definitive discharge checklist, where every single medication acts as a shield against a specific long-term threat. First, low-dose aspirin is prescribed indefinitely to keep platelets calm. Second, a high-intensity statin like atorvastatin 80 mg or rosuvastatin 40 mg is locked in to manage cholesterol and stabilize whatever plaques remain. Third, we mandate an ACE inhibitor. This one is absolutely vital because it directly combats that dangerous ventricular remodeling we talked about and helps prevent heart failure. We also include a beta blocker for at least 3 years, or indefinitely if their ejection fraction dropped to 40% or lower to reduce recurrent ischemia. We make sure to send them home with sublingual nitroglycerin just in case they need emergency symptom relief. And finally, if they have heart failure or diabetes, we add an aldosterone antagonist to further reduce mortality risk. But I'll be honest, the trickiest part of discharge planning is getting the timeline for dual antiplatelet therapy, or DAPT, exactly right. We already have them on aspirin, right? But we also need a P2Y12 inhibitor. If a STEMI patient was managed purely medically, without a stent, they need this combo for a minimum of 14 days. However, if our patient went to the cath lab and had a stent placed, whether that was for a STEMI or an NSTEMI, they absolutely must remain on a P2Y12 inhibitor for a minimum of 12 months. This is entirely non-negotiable. If they stop, platelets will rapidly clump onto the foreign metal of that new stent, and it will cause a catastrophic subacute stent thrombosis. So look at what we've done. We've explored the biological crash, we raced against that 10-minute ECG clock, navigated the incredibly complex pathways of PCI and pharmacology, and we finally sent our patient home with an optimized, life-saving pill box. But I think this leaves us with one final pretty provocative question. We've repaired the plumbing and we've optimized the pharmacy, sure, but are we truly treating the underlying systemic disease? True secondary prevention doesn't just come in a pill bottle. Ultimately, our patients' survival relies on them tackling the modifiable risk factors that got them into the ER in the first place, managing their diet, quitting smoking, and getting obesity and diabetes under control. The hospital clock has been reset for sure, but keeping it ticking is ultimately in their hands. As medicine continues to evolve, we really have to ask ourselves, will our future rely on building better stents and creating stronger drugs, or on a radical shift in how we prevent systemic disease in the very first place? Thank you so much for joining me for this explainer on acute coronary syndrome.